to the next speaker, which is Keith Channon from Caristo. Good morning.
Thank you very much, Chairman, ladies and gentlemen. It's a pleasure to update you on CaRi-Heart technology for comprehensive assessment of coronary plaque and inflammation. We've all been brought up as clinical cardiologists and as imagers with a focus on coronary plaque as the embodiment of coronary artery disease. And of course, that's crucial for patient management, particularly symptoms and revascularization. But there is increasing understanding that our historical focus on plaque gives us an incomplete picture of disease activity and risk. And this recent study, bringing together more than 30 different studies and 30,000 patients with the editorial in JACC Cardiovascular Imaging, indicates that there is more to coronary artery disease than the embodiment that we see in plaque alone. And this was demonstrated recently by looking at a large data set gathered from 8 NHS hospitals in the UK as part of the ORFAN study led by the Oxford group, presented at the AHA late last year, which in 40,000 scans, these were scans done for clinical reasons and followed up for up to 10 years, you can see that patients who had obstructive coronary artery disease on the index scan did indeed have a higher rate of both cardiac mortality and MACE over the follow-up period, as would be expected and as demonstrated in other large cohort studies. However, the patients who did not have obstructive disease did not have a benign outcome. There was still a relatively high event rate in the patients who had no obstructive disease. So this is, of course, compounded by the fact that the overwhelming majority of patients referred for clinically driven CT coronary angiography do not have obstructive coronary artery disease. Only about a fifth have obstructive disease. So although the rate of cardiac mortality and the rate of MACE is 1.5 to 2-fold higher in those patients, the aggregate result is that more cardiac events and deaths occur in the group of patients referred for CT coronary angiography who do not have obstructive disease. And this is a real challenge for us as we diagnose and manage our patients. And of course, we see that day in, day out with our patients and our scans. Here are two fairly similar looking patients, middle-aged men with chest pain, the usual range of risk factors. Their coronary CT angiograms show the sort of patterns of disease that we routinely see. Both patients were treated with routine medical therapy, but their outcomes were very different. And the missing piece, if you like, is the fact that coronary inflammation was invisible on a routine CT coronary angiogram, but the patient on the left had no cardiac events over an 11-year follow-up, whereas the patient on the right, in fact, had a fatal outcome. And when those scans were subsequently analyzed retrospectively using the CaRi-Heart technology to evaluate coronary inflammation by the analysis of perivascular adipose tissue attenuation index, or PHI, you see a very different picture. And of course, we now know that inflammation in the coronary artery wall is a fundamental aspect of coronary artery disease pathophysiology. It's the driver of plaque progression, and it's also the initiator of plaque events that lead to both mortality or MACE. We've seen that in multiple phase 3 pivotal trials, which show proof of concept that targeting inflammation is a valid therapeutic option that improves outcomes. And we now, of course, have clinical guidelines recommending that anti-inflammatory drugs can be considered in patients at high risk. The challenge is identifying who those patients are in order to target our therapies more accurately. This topic has been prominent recently, and you can see that many of you will have seen in this month's circulation cardiovascular imaging studies showing that the assessment of coronary inflammation adds important additional information to the assessment of plaque. And there's a nice editorial from Dr. Ferencik that I'm sure you'll have read as well, showing that non-invasive imaging of coronary artery inflammation carries a major potential for improving diagnostic and prognostic manifestation of our patient. And this is where the CaRi-Heart technology comes in, which is able to characterize and quantify coronary plaque, inflammation, and risk all in one application. And CaRi-Heart generates the following report, and that has three important aspects to it. First of all, for each of the three main coronary arteries, CaRi-Heart calculates the Phi score, the Fat Attenuation Index Score, which is an individualized quantification of coronary inflammation in each of the three main coronary arteries, adjusted for age and gender. So each artery for each patient receives a score on a percentile value, and this is a measure of disease activity. It's not a measure of disease structure or obstruction, it's the fundamental activity. It also generates a comprehensive assessment of coronary plaque with all of the usual detailed parameters of plaque volume, distribution, plaque composition, etc. And it puts all of this information together for the individual patient into the CaRi-Heart risk. The absolute risk, it calculates from those aspects that I've mentioned, the individualized risk of a fatal cardiovascular event within the next 8 to 10 years. So it's a comprehensive assessment of that patient's disease and, importantly, their risk, based not just on structural aspects, but on the coronary inflammation. And as I've already shown you, that's a major important driver. CaRi-Heart is delivered via a cloud-based portal. It can analyze any scan from any manufacturer's platform. It's been calibrated for all of those, and it's already cleared for clinical use in many parts of the world, including the UK and EU. Finally, I just want to show you some exciting recent data presented in the AHA late-breaking science session last November related to the ORFAN study. And this shows that when we take that cohort of patients that I mentioned before, and I showed you how obstructive disease predicts a moderate increase in risk, we've now been able to analyze about 4,000 of those CT scans using the CaRi-Heart application to quantify coronary artery inflammation. And so these Kaplan-Meier curves show the outcome for patients stratified by quartiles of their Phi score. Phi score is the quantification of coronary inflammation. In these graphs, I've shown you the Phi score for their LAD, but the graphs look almost identical if you use the right coronary artery or the left circumflex. And on the left, you see cardiac mortality over follow-up up to 10 years. The median follow-up was about 4 years. And on the right, you see MACE, and the pattern is very similar. And what's very striking is that on top of anatomic distribution of disease, clinical risk factors, age and sex, those have all been corrected for in these Kaplan-Meier curves. You can see that the quantification of coronary artery inflammation is a major driver of mortality and MACE outcomes, such that if you are in the top quartile, the top 25% of people with inflammation scores in their LAD that are high, you have a 20-fold hazard ratio of death in the 10 years following your index scan, and about a 7-fold for MACE. Now, of course, this is in all patients referred for clinically driven CT scan. And so the Oxford group next looked at the patients who have no coronary artery disease. They have no plaque, no calcium. In other words, their CAD-RAD's 0. And I think this is the most sobering result, that if you again stratify them by their LAD Phi score, so this is the quantification of coronary inflammation in patients who have no plaque and no calcium, and incidentally we found that that was about 32% of this population of patients. Patients in the highest quartile, the 25% of patients in the highest quartile of LAD Phi score, even though they have no plaque or calcium, have got a risk of mortality or MACE in the following 10 years, which is comparable to patients who have advanced disease. So this is a very important new insight into the importance of coronary inflammation as an additional predictor of risk. So just briefly to show that CaRi-Heart, the technology, Caristo's technology, is already being implemented in the National Health Service in the UK. We did a real-world survey to ask how this technology might change clinical management in 4 hospitals in about 800 patients. And the summary here is that about 55% of patients, about half of patients, when CaRi-Heart was implemented retrospectively on their CT scans, did not have a change in clinical management, but that there was a clinical management change in about 45% of patients when the scans were subsequently reanalyzed using the CaRi-Heart technology. So this indicates that the implementation of CaRi-Heart on top of routine clinical CT interpretation has the potential to change management in a substantial number of patients. And that is now being implemented in a larger study in 5 NHS hospitals shown here to look how a risk-based evaluation, rather than only a plaque-based characterization, can change the way that we stratify and treat our patients, to look at how this improves outcomes and indeed reduces costs. We're working closely with many private clinicals and hospitals in the UK, and we're very excited to have just undertaken a new partnership with the pharmaceutical company who has the marketing for colchicine, to look at how targeting patients with high inflammation may be able to help direct and stratify patients for the use of anti-inflammatory drugs. So in summary, in patients undergoing CT coronary angiography, it's sobering to note that the aggregate majority of events occur in those patients who do not have obstructive disease on their index scan. Measuring coronary inflammation using the CaRi-Heart application is able to strongly predict both fatal and non-fatal events independently and in addition to clinical risk factors and plaque. And this has the potential to make major changes in clinical management. Therefore, Caristo's CaRi-Heart technology to quantify inflammation, plaque, and risk assessment has the potential to really change the way we understand coronary artery disease and manage our patients. Thank you.